Good morning and welcome to Health Matters with Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're glad you joined us. Before we begin, I'd like to thank our sponsors, Cleveland Clinic Mercy Hospital, Studio Arts and Glass, and of course, our socially distant technical producer, J.D. DeAngelis. Today, Brad and I are broadcasting from our administrative offices, and our very special guest is Dr. David Gutlove, anesthesiologist and medical director of Cleveland Clinic Mercy's Pain Management Center. Good morning, doctor. Welcome back to the show. You know, you were last on us back in 2014, and I think there's probably been a lot of pain between 2014 and now. So we are so happy to have you back and during our 10th anniversary celebration on Health Matters.
Thank you for inviting me.
If you live with pain, you're not alone. In a recent study, researchers from Brigham and Women's Hospital and Massachusetts Eye and Ear, both Harvard University hospitals in Boston, report that 50 million, about 20% of US adults experience chronic pain. No matter what type of pain you suffer from, it's important for you to learn the most effective way to relieve or manage it. This morning, we will talk with Dr. Gutlove about pain from shingles, treatments, and other conditions related at the Cleveland Clinic Mercy Hospital Pain Management Center. We'd like to remind our listeners that this program is available on our podcast. You can download and subscribe it using your favorite smartphone app for podcasts. Just look for Medicine Center Pharmacy with Health Matters, and you can listen to any of our programs anytime.
So it's an exciting time in our pharmacy as we celebrate our 45th anniversary by giving away $45 gift certificates to anyone who stops in to register. Please stop by and register so you have a chance of winning next week. We're giving away gift certificates to Lindsay's Restaurant, Anastasiades Chocolates, Grinders and Above and Beyond, and Kishman IGA. So again, Dr. Gutlove, welcome back to the show. Thank you for your service to the community during this pandemic. You and all healthcare workers are appreciated. Please tell us a little bit about yourself and introduce yourself again to our audience.
Okay. Well, thank you again for having me. My name is Dave Gutlove. I'm the medical director of the Pain Management Center, Cleveland Clinic Mercy Hospital here in Canton. I've been in Canton since 1996. Prior to that, I did a fellowship in pain management at Stanford University in California, and prior to that, I was serving in the United States Air Force overseas and in various different bases.
So when does pain become chronic?
Well, typically the hallmark or benchmark figure that people tend to quote is 6 months. So if a pain lasts more than 6 months, supposedly it is chronic. However, really the definition of chronic pain is pain that persists longer than the normal healing process. For example, if someone has an ankle sprain, say an uncomplicated grade 1 ankle sprain, it's treated with ice, elevation, anti-inflammatory medications, rest, maybe an ankle brace or walking boot, and gradual remobilization. If the pain still persists in that individual after, say, 8 weeks, by definition, it's become chronic. Provided there's no other cause that's causing the pain. So 6 months again is the number that people tend to throw out, but it's really pain that's persisted longer or the normal healing process for whatever ailment we're talking about.
So this is probably a long answer here, but what conditions can cause chronic pain?
Oh, anything and every condition from migraine headaches to cancer pain to fibromyalgia and everything in between can, under certain circumstances, become unremitting, chronic, unrelenting, etc.
Where did that fibromyalgia term come from? I remember years ago that the insurance companies were kind of laughing at that so-called new diagnosis. Where did it come from?
I believe it may have been back in 1991, the American College of Rheumatology coined the phrase fibromyalgia, and actually before that, there were other terms that were used. But the definition from the American College of Rheumatology, I believe, and again, it's 1991, or don't quote me on the exact year, was that a patient needed to have chronic pain lasting, again, more than 6 months duration, no other explanation for the pain, altered sleep cycles, and involving at least 11 of 16 different areas in the body that were painful or that are painful.
All right, doctor, let's talk about shingles. You know, during the pandemic, we've heard a lot about COVID and a lot about those symptoms, but I feel like a lot of patients who were getting vaccinations regularly for shingles when they became eligible has maybe fallen to the wayside. So can you talk about shingles, what it is, and some of the struggles you see on a daily basis with patients?
Certainly. First of all, herpes zoster or shingles is an acute infectious disease. It's caused by the varicella virus, the same virus that causes chickenpox, belonging to the DNA group of viruses. It's a virus that can cause not only shingles or acute herpes zoster, but also subsequently post-herpetic neuralgia. Now, how does it occur? Most of us have chickenpox as a kid. Okay, we recover completely, or seemingly we do. So the chickenpox goes away and the virus goes away as well. However, it really does not go away, okay, but rather it lies dormant near the spinal cord, something we call the dorsal root ganglion it's a certain part of the spinal cord. And it can reactivate itself during times of stress, when someone's in an immunocompromised state, when our immune systems are busy fighting off other invading pathogens. And that may be a time when this an opportunistic virus such as herpes zoster reactivates itself.
Interesting. All right. So you kind of covered what it is and what causes it to become non-dormant, if you will.
That's a good question. Again, when people are under undue stress, an immunocompromised state, where our bodies are busy fighting off other infections, it may be a time for an opportunistic virus, such as the shingles virus or herpes zoster, to reactivate itself. So it typically occurs, again, if someone's has a low immune system, someone is advanced age, someone is under undue amount of stress, etc., is typically when we see it reactivate itself.
What kind of percentage of the population suffers from shingles outbreaks?
It's actually, I think statistically, it's about 125 per 100,000 annually. It affects men and women equally, so that it's an equal opportunity invader. There's no seasonal variation, so winter, spring, summer, fall would be the same. It's relatively rare in children. It's about, instead of 125 per 100,000 in children, it's about 1 per 100,000. So 1 per 100,000. And interesting enough, in patients in their 80s, the numbers increase dramatically to about 5 in 100 or 1 in 20. So obviously the incidence increases with increasing age, likely due to our waning immune surveillance or decreased immune response as we age. And it's certainly more common in immunocompromised patients. So patients that are undergoing chemotherapy, radiation therapy, bone marrow transplants, etc., are much more prone to developing shingles, acute herpes zoster.
Well, you talk about assaults on the immune system, and that makes me think of COVID. So is there a connection between COVID and shingles?
Well, there seems to be yes and no. I guess the easy answer is yes. Interestingly enough, data collected in Italy, France, and Brazil have shown an increased incidence of shingles or acute herpes zoster in patients who have had either COVID-19 infection, and or the SARS-CoV-2 vaccine. However, studies coming out of this country, at least that I'm familiar with in UCLA and Stanford, have failed to demonstrate such a correlation. Now, intuitively, there should not be a direct cause between the COVID virus infection and acute herpes zoster shingles. Why? Because they're entirely different virus types. They're very different. It's possible, however, that the stress that this pandemic has wreaked on the entire world, with altered lifestyles, social distancing, loss of jobs, etc., can certainly make us more prone to the shingles outbreak. And that's probably where the connection is. And anecdotally, I have to say that in my patient population, I've seen an increase in my own practice since probably March of last year, March of 2020, when we first were introduced to the ugly COVID virus, et cetera. Anecdotally, I've seen an increase in number in my practice.
I've had people come to me and say, Paul, you got to help me. I'm really suffering big time. So what are some of the symptoms associated with shingle?
Well, typically it's an abnormal sensation, excuse me, where patients will have a lancinating, burning type pain, and there's something that we call dysesthesias, where it's kind of an abnormal, unpleasant sensation, typically caused by nerve damage. And they may develop something called allodynia, which is pain that's provoked by a normally non-noxious stimulus. So simply bed sheets brushing over the area, clothes, a fan, etc., will hurt dramatically in a dermatomal distribution. By dermatomal, I mean by where the nerves will manifest themselves along the skin. And it usually involve one or more affected nerve roots. 50% of the time it occurs in the thoracic area, which is along the chest wall cavity. So people have chest pain, or at least chest wall pain, which is again is potentially or should be different than cardiac pain. 10 to 15% of the time it's in ophthalmic division, so by the eye or face. About 10 or 15% of the time would be sciatic distribution, so in the buttocks and maybe down the leg. It's typically unilateral, which means on one side, not both sides. It can be associated with fever, something we call malaise, which means patient just feels ill, headaches, diffuse adenopathy, which really means patient has swollen lymph nodes. And interestingly enough, the rash appears 3 to 5 days after the onset of pain. That's important. So after the onset of pain, 3 to 5 days later is when the rash typically appears. The rash later on, after several weeks, will recede. The vesicles get crusted over. There's kind of hypopigmentation of skin or kind of blanching of the skin, and the pain resolves. Unfortunately, in about 15 or 20% of patients, it's age dependent and also dependent upon the severity of the shingles outbreak. The pain will persist even after the rash dissipates. And this is something we call post-herpetic neuralgia.
Incredible. Gosh. So, okay, what other ailments can mimic shingles?
Well, again, before the hallmark or classic vesicular rash appears, which again typically appears 3 to 5 days after the onset of pain. So now if we're just talking about the pain before the rash appears, the pain can be mistaken for coronary-related pain. So patients could have chest pain and think it's something to do with the heart, when in reality it may or may not. But that's a slippery slope. Obviously, if they think it's cardiac, that needs to be ruled out first. So that's first and foremost. Something we call pleurisy, which is kind of inflammation of the lining of the chest wall or pulmonary viscera from infections or inflammatory process. Something we call costochondritis or Tsetse syndrome, which is really kind of pain by the angle between the sternum and where the ribs connect to it. Pericarditis, which is an inflammation of the sac of the around the heart. Even spinal mediated pain. So if someone has a disc herniation in, say, the thoracic spine, which is the middle part of the spine, that can cause pain that radiates around the chest wall and can mimic the pain associated with shingles. To make it even more confusing, there is a syndrome that I've seen a few times in my medical career called zoster sine herpete, which is a Latin term. It basically means zoster pain, but the person never gets the rash, never develops a rash.
Okay, we got to take a break here, Doctor. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. It is our 45th anniversary, and we'd like to invite you to transfer your prescription to the Medicine Center Pharmacy to receive a $25 gift certificate. It's simple. Just call and talk with our pharmacist. So, Doctor, how about this? What is post-herpetic neuralgia?
In about 5 to 20% of patients with acute herpes zoster shingles will have persistent pain even after the rash heals and disappears. Again, as I said before, there's an instance that increases with increasing age, and also the severity of the shingles outbreak. So someone who is older and or has a more severe case of shingles is more prone to developing post-herpetic neuralgia. So persistent pain, chronic pain that occurs after the rash resolves is defined as post-herpetic neuralgia. And unfortunately, it's one of the most difficult problems that we encounter as providers, as physicians, as nurse practitioners, PAs, etc. Few other conditions create so much pain and suffering for patients as post-herpetic neuralgia does.
Gee whiz. So what treatments are available for shingles and post-herpetic neuralgia?
Well, there's really a myriad of treatments that are available. We'll categorize them starting with, I guess, pharmacologic treatments or medications. Let me preface it by saying that there's no single treatment that's 100% effective, and therefore we tend to use what's called a multimodal approach, approaching it from many different facets or different angles, medications, injections, etc., which we'll go over. And the key point that I really want to emphasize, and this is probably the take-home point, is that the earlier the institution treatment, the less likely the patients develop post-herpetic neuralgia. So to reiterate, patients with acute herpes zoster should be treated aggressively and early using a multimodal approach in order to decrease the incidence of post-herpetic neuralgia. That's the most important take-home message. As far as, if you want me to continue, as far as a pharmacologic treatment, number one, I guess we start with antiviral medications. So antiviral agents such as acyclovir, famciclovir, valacyclovir are standard treatments for patients with acute herpes zoster. And just a little background on that, the herpes zoster virus, like all viruses, is a parasite. So it takes over healthy cells and uses the host DNA to reproduce itself. So these antiviral agents work by essentially masquerading as one of the building blocks of the DNA needed by the virus to replicate itself, thereby stopping the virus from reproducing itself. So the medications can decrease the duration of acute herpes zoster and the decrease of pain from shingles. If you want me to continue, I can.
Sure.
Next category would be, I guess, again, still talking about pharmacologic or medications, would be analgesics. And a plethora of analgesics have been utilized to treat both acute herpes zoster and post-herpetic neuralgia, including probably over-the-counter Tylenol, aspirin, NSAIDs, to prescription medications such as codeine, tramadol, Norco, Percocet, etc. Potential side effects of these medications obviously can cause CNS side effects, so patients feel dizzy, etc., or constipation. Oral steroids, interesting enough, such as prednisone, may shorten the duration of acute herpes zoster, but really have not been shown to decrease the efficacy of preventing post-herpetic neuralgia. So while it may help in decreasing the pain and duration of acute herpes zoster, it doesn't necessarily prevent the patient from developing post-herpetic neuralgia.
Wow. It's amazing.
There's other categories if you want me to continue, or
yeah, what about shoot, it escapes me. They're using it for pain also, using it for epilepsy and other things.
Neurontin and Lyrica, those medications. Yeah, the so-called anticonvulsants or membrane stabilizers. Certainly Neurontin and Lyrica, or Neurontin being gabapentin, Lyrica being pregabalin, have shown to decrease pain, improve mood, quality of life, improve sleep cycles, etc., and are used for a whole host of different chronic pain issues, including post-herpetic neuralgia. Absolutely. The doses typically, at least the studies indicate, doses have to go fairly high if the patient can tolerate it. With gabapentin, the doses are up to like 3,600 milligrams a day. And with Lyrica or pregabalin, the doses are around 600 milligrams a day. So obviously, as we increase the dose of any medications, patients are more prone to developing side effects. With those specific medications include sedation, double vision, forgetfulness, unsteady when they're standing, lower extremity swelling. Those are potential side effects of medications.
Gosh, there's a whole plethora of stuff here. How do you choose which one to use, or do you just go down the road?
Well, typically is again a multimodal approach. So certainly the antiviral agents are the first one to start with. When the patient develops shingles, antiviral agents, and then analgesics, giving them something to help with pain. If they're also having difficulty sleeping, a lot of times physicians will add antidepressant medications such as Elavil and/or Neurontin or Lyrica, which again are the anticonvulsants or membrane stabilizers. So it typically has to do with the comfort level of the provider who's prescribing the medication for the patient. But as far as a multimodal approach, in addition to the medications, it's important to try other things on top of that.
Do you see patients bad enough to prescribe narcotics? I mean, that brings on a whole lot of problems.
It does. I mean, that's a whole other topic for a different day. It does. Typically, if we're going to use narcotics to treat pain that's severe for acute herpes zoster, shingles, or even post-herpetic neuralgia, we tend not to provide it or prescribe it, I should say, on a long-term basis. We tend to try to do it on a short-term basis to provide the patient enough benefit where the healing process takes over, and some of the other modalities that we use, not just medications, but other things that we can do.
Okay, doctor, time for the news. You're listening to Health Matters with the Medicine Center Pharmacy. Okay, welcome back to Health Matters with the Medicine Center Pharmacy. Today we're talking with Dr. Gutlove from Pain Management, Cleveland Clinic Mercy Hospital. So what types of procedures do you offer in the pain management center? Now, we kicked this around a little bit, but are you using sound therapy and X-ray therapy and just what do you champion, I guess is the right.
X-ray therapy and ultrasound therapy, from a therapeutic standpoint, no. We use those from a diagnostic standpoint. We'll be doing procedures, and we typically will use fluoroscopy, which is a C-arm, or it's a portable X-ray machine that we'll use to guide us doing procedures all the time. So we offer a myriad of different procedures or injections, from epidural steroid injections, trigger point injections, which are done into the muscles, tendons, or ligaments, selective nerve root blocks, which are targeting specific nerves, facet blocks, which is it's a different specific area of the spine, something called medium branch blocks, which are temporary nerve blocks to say whether or not the patient's a candidate for radiofrequency ablation, which is going in and burning the nerves, which has shown a lot of efficacy in parts of the spine. Shoulder injections, knee injections, hip injections, something called genicular nerve blocks, which are specific, specialized injections of nerves around the knee. Infusions, I think I alluded to before, or at least I mentioned it before briefly, infusions of IV lidocaine or intravenous lidocaine, or something called intravenous ketamine, which has shown a lot of promise in treating neuropathic pain states or nerve-related pain. Spinal cord stimulation, which are implants that we do. Botox injections, typically for chronic spasms, torticollis, or even headaches, chronic headaches. And pump placement, placement of a pain pump.
Interesting. Well, the internet and TV and cable and all that stuff abound with alternative therapies that they claim are going to change your life. Have you found any alternative therapies out there that you think are of any value?
In my opinion, yes. I think certainly if a patient believes in those modalities more, like anything else, it's more efficacious. So if a patient believes that their doctor is very reliable and expert in their field and goes to see a doctor, and the doctor prescribes medicine X, Y, and Z, and the patient actually believes it's going to work, it's much more efficacious or effective than if the patient has no confidence in the provider. Same thing with alternative therapy. So if a patient believes that acupuncture is going to work, I think it certainly is going to be more effective than if they have no belief in it. I mentioned before some other modalities like stem cell and PRP, which is platelet-rich plasma, which are not FDA approved, but they've shown a lot of efficacy, or at least in anecdotal reports, specific reports have shown efficacy in very difficult to treat conditions. Even some patients who go to see the providers in town that do medical marijuana or have medical marijuana clinics, some patients will say it helped them tremendously, and others say it didn't do anything except lighten their wallet.
Okay.
Yeah.
How about the new product? It's not new, but it has just come in the marketplace over the counter, the Voltaren gel. Or have you tried that on anybody? And what are you thinking on that?
I have. Tends to work fairly well if someone has mild to moderate arthritis of a joint, say in the knee or shoulder area. More severe arthritic conditions tends to be less effective, I should say.
I encountered a lady a couple nights ago that was using it on her hands because she had severe arthritis in her hands, and she said it seems to work pretty well. So, but this lady's been through surgery on the knuckles and all kinds of stuff. So over the years, but she's tried about everything. But she said currently that seems to work fairly well for her. So
Tends to have less side effects. If someone is intolerant to NSAIDs or non-steroidal anti-inflammatory drugs, and they really can't tolerate, say, the Motrin, ibuprofen, Advil, Aleve, or prescription medicines in that category because of GI upset, etc., the creams or gels tend to be better tolerated, although there is some systemic absorption, and sometimes patients will complain of GI upset when they're putting on the Voltaren gel or the or other creams that have NSAIDs in it.
Okay. You have a question, Brad?
Yeah, Dr. Golub, how about, can you share your contact information with our listeners if they would like to get in touch with your practice?
Sure. It's Cleveland Clinic Mercy Hospital. The main phone number is 330-489-1478. So 330-489-1478. And we actually have 3 sites thus far. So it's Cleveland Clinic Mercy Hospital here in Canton. There's a Jackson location. There's an Alliance location, which is across from Mount Union. And soon we're going to be setting up a 4th location with a Tuscarawas office. That's
okay.
going to be very soon.
And
Interesting.
do you have a practice in all those locations?
Me personally, no, at 2 locations, and Cleveland Clinic Mercy Hospital in Canton here, so the main hospital, and then Alliance. Every Wednesday right now, I'm in the Alliance office.
Okay. Do you have any parting info you'd like to leave with our listeners today?
Regarding, again, post-herpetic neuralgia and shingles and acute herpes zoster, et cetera, just to reemphasize probably for the 4th, 5th, or 6th time, or maybe more, regarding shingles. The treatment of shingles should be early on and aggressively treated using a multimodal approach to decrease the likelihood, decrease the chance the patient's going to develop post-herpetic neuralgia.
Interesting. Do you have any statistics on how many people in America have symptoms?
Have post-herpetic neuralgia symptoms?
Yeah, or well, actually, who actually have the disorder, if you will.
Statistic-wise, no. It's fortunately enough, it's not that common because it only occurs in about 5 to 20% of patients. But in my practice over the years, I've seen, I'm sure, close to 100 patients or more, maybe more than that are still suffering from post-herpetic neuralgia years later after the rash dissipated.
Smokes, huh? Okay, Dr. David Gutlove, anesthesiologist and medical director of Cleveland Clinic Mercy Hospital Pain Management Center. We'd like to remind our listeners, if you suspect you have a medical issue, please contact your healthcare provider. Excuse me. Thanks to our sponsors, again, Cleveland Clinic Mercy Hospital, Studio Arts and Glass, and of course, our technical producer, JD DeAngelis. As always, we thank you listeners for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week, and we'll see you again next Friday right here on News Talk 1480 WHBC.